And if nobody is reviewing the full picture, your heart may end up paying for decisions made one symptom at a time, one refill at a time, until no one remembers to ask whether the whole plan still makes sense. That is how older adults get hurt. Usually not by one shocking decision, by routine, by habit, by trust without review. Let me leave you with this. Your heart has worked for you every second of every day of your life. It has kept going while you slept, while you grieved, while you worked, while you raised children, while you lived through every ordinary and extraordinary day that made your life your life. It deserves more than automatic prescriptions and casual refills. It deserves exquisite care. And sometimes exquisite care begins with one simple question. Looking at the bottle in your hand and asking, "What is this doing to my heart?" That question can change everything. Imagine finding out that the thing quietly weakening your heart was never disease at all. It was something you trusted, something you may have taken this morning, something sitting in your bathroom cabinet right now. A pill for pain, a tablet for reflux, a cold medicine you grabbed because your nose was blocked, a medication for sleep, mood, or nerves, even a supplement you thought was protecting you. And while you were taking it in good faith, trying to feel better, trying to stay comfortable, trying to do what responsible adults do, it may have been quietly putting strain on the one organ in your body you cannot afford to lose even a little function in. Your heart, not some strange experimental drug, not a black market chemical, not a rare poison. Common medications, ordinary medications, the kind people over 60 take every day without fear. I'm Dr. Adrian. And after years of caring for older adults with heart failure, arrhythmias, fluid overload, blood pressure spikes, coronary disease, and sudden cardiac decline that families never saw coming, I need to tell you something very clearly. Some of the medications people trust most after 60 can quietly weaken, overload, destabilize, or inflame the heart. Not because every medication is bad, not because doctors are trying to harm anyone, not because treatment is the enemy, treatment saves lives, but because the aging heart is not the same heart you had at 35. It is stiffer, less forgiving, more sensitive to fluid shifts, more sensitive to blood pressure changes, more sensitive to electrolyte loss, more vulnerable to dangerous rhythm changes, more vulnerable to the cumulative stress of small medication effects that a younger body might shrug off. And that is what makes this conversation so serious, because people rarely recognize a medication problem while it is still a medication problem. They recognize it when it becomes shortness of breath, swollen ankles, chest pressure, a racing heartbeat, dizziness, weakness, a fall, a hospital admission, an emergency room visit that seems to come out of nowhere. And by the time the connection is finally made, the drug that helped one symptom may already have been quietly injuring something much more important. That is why I need you to stay with me all the way through this. Because I'm going to walk you through 5 of the most common medication categories that can secretly strain, weaken, or destabilize the heart after 60, why they become more dangerous with age, and what you need to ask before you take the next dose. And the number 1 item on this list is the one that shocks people most, because millions of older adults take it believing they are protecting their future, while it may be doing the exact opposite to their arteries. Before we begin, let me say something that matters. This is not a message telling you to throw away your medications. Do not stop anything suddenly because of this conversation. Some of these drugs may still be appropriate for you. Some may be useful but need closer monitoring. Some may only be dangerous in certain doses, durations, or combinations. Some may need safer alternatives. Some may need a conversation, not a panic reaction. This is not about fear. This is about awareness, about asking better questions, about protecting the heart before it pays the price for a decision that was never fully explained. Let me start by telling you why this matters so much after 60. When people are younger, the heart has more reserve. The kidneys regulate fluid more efficiently. The arteries are more flexible. The heart muscle tolerates stress better. The electrical system is often more stable. Blood pressure recovers faster when something pushes it in the wrong direction. And if a medication causes a mild fluid shift, a modest pressure increase, or a small electrolyte change, there is often enough resilience to absorb it. After 60, that margin begins shrinking. After 70, in many people, it shrinks dramatically. The heart may already be pumping against stiff arteries. The kidneys may already be clearing medications more slowly. The blood pressure system may already be more fragile. There may already be hidden coronary artery disease, mild valve disease, diabetes, kidney impairment, or years of vascular wear that nobody can feel day to day. So now imagine adding a drug that causes the body to hold salt and water, or a drug that tightens blood vessels, or a drug that drains magnesium, or a stimulant hiding in cold medicine, or a medication that destabilizes heart rhythm, or a supplement that changes calcium handling in the bloodstream. The younger body may have shrugged, the older body may not. That is the real issue. It is not just the medication. It is the medication inside the wrong physiology, and older adults deserve to hear that plainly. Now let's begin with number 5. NSAIDs, non-steroidal anti-inflammatory drugs, ibuprofen, naproxen, diclofenac. The pills millions of people rely on for joint pain, back pain, arthritis, headaches, dental pain, and all the ordinary aches that become more common with age. And that is exactly why they are so dangerous. Because they work. They really do work. They reduce pain, they lower inflammation, they make movement easier, they let people get through the day, and when something helps that much, people stop questioning it. Sometimes, they stop questioning it for years. I want you to picture a man in his early 70s. Let's call him Michael. He loves gardening. That garden is not just a hobby. It is his peace. It is his routine. It is one of the last places he still feels fully like himself. But his knees ache. His back aches. So he starts taking ibuprofen regularly, not recklessly. Not handfuls at a time, just enough to keep moving. A few tablets most days, more on bad days. It feels harmless. Then things shift. His socks start leaving deeper marks around his ankles. His shoes feel tighter by evening. He gets a little more winded climbing stairs, then more winded walking uphill. Then one afternoon, doing something ordinary, he has to stop because he cannot catch his breath. By the time he reaches the hospital, the problem is not his knees. It is his heart. It is overloaded. Struggling. Drowning in fluid it should never have been forced to carry. And the trigger was not some mysterious new heart disease. It was the safe anti-inflammatory he trusted almost every day. How does that happen? Because NSAIDs do not just reduce pain. They also interfere with prostaglandin pathways the kidneys and blood vessels depend on to regulate fluid and circulation properly. When those pathways are blocked, two dangerous things can happen. First, the body starts retaining salt and water. That matters enormously, because the heart is a pump, and when the body suddenly starts carrying more fluid than it should, the pump has to push harder against more volume. A younger heart may tolerate that better. An older heart, especially one already dealing with high blood pressure or stiffness, may not. That is how swelling starts. That is how shortness of breath starts. That is how fluid overload starts. That is how heart failure can declare itself. Second, NSAIDs can raise blood pressure, sometimes quietly, sometimes significantly. They can constrict blood vessels and also interfere with the effects of blood pressure medications. So now the same person who thought their pressure was under control can find it climbing for reasons they never suspect. Think about that combination. More fluid, more pressure, an older heart already working harder than it used to. That is not a small issue. That is a setup. And there is another layer people almost never hear about. If you take low-dose aspirin for heart protection, some NSAIDs can interfere with aspirin's protective antiplatelet effect. So now the same person trying to protect their heart may be accidentally weakening one of the things meant to protect it. That is why I tell people after 60 something they do not expect to hear. Regular NSAID use is never a casual conversation if you have high blood pressure, swelling, kidney issues, coronary disease, shortness of breath, heart failure history, or even just a heart that is not as resilient as it once was. It deserves respect. Now, to be clear, this does not mean no one over 60 should ever take ibuprofen or naproxen. It means the lowest effective dose for the shortest necessary time is very different from daily, casual, chronic use that goes on for months or years without review. And if pain is chronic, the answer is not simply to keep swallowing the same pill forever without asking what it may be costing the heart. That is the right question. Not just, does this help my pain? But, what is this doing to my kidneys, my pressure, my fluid balance, and my heart while it helps my pain? That question can prevent a great deal of harm. Now let's move to number 4. Proton pump inhibitors. Omeprazole, pantoprazole, lansoprazole. The medications millions of people take for reflux, heartburn, gastritis, or stomach protection. These are some of the most underestimated long-term medications in older adults because they do not feel like heart drugs. They feel protective, gentle, responsible, just a stomach pill. That is why almost nobody thinks to connect them to the heart. But the heart cares very deeply about something these medications can quietly disrupt: magnesium. And magnesium is not a minor lab number that only interests doctors staring at a chart. Magnesium is one of the minerals the heart depends on for electrical stability. When magnesium falls too low, the heart can become more irritable, more unstable, more prone to palpitations, skipped beats, rhythm changes, and in the wrong person, dangerous arrhythmias. I want you to picture a woman in her late 60s. Let's call her Helen. She started a reflux medication years ago because the burning was miserable. The pill worked beautifully, so she stayed on it. Months became years. No one questioned it. No one reviewed whether she still needed it. No one asked whether the dose could be lower. No one checked what it might be costing. Then something changes. She feels more tired, a little weak, maybe occasionally lightheaded. Maybe she notices strange flutters in her chest that come and go. At a routine visit, something looks off. An ECG is not quite right. Blood work shows low magnesium. And suddenly the harmless reflux pill is no longer just a reflux pill. It is part of a cardiac problem. That is how routine hides danger. It wraps it in familiarity. Now, again, I want to be fair. Some people genuinely need long-term acid suppression. There are real reasons: ulcer disease, bleeding risk, severe reflux, complicated stomach issues. This is not a blanket condemnation. It is a warning against automatic continuation without reevaluation. Because once a medication stays on the list year after year, it can start affecting nutrient absorption and body chemistry in ways that reach far beyond the stomach, and the heart is one of the organs that pays attention. There is also another concern. Some observational research has raised questions about long-term PPI use and increased cardiovascular risk through possible effects on vascular biology and nitric oxide balance. That relationship is still debated. But when you combine that uncertainty with electrolyte depletion and potential interactions with cardiovascular medications in some people, the picture than most patients realize. This is why the right question is not, is omeprazole safe? The right question is, do I still need this at this dose for this long? And what is it doing to the rest of my body while it protects my stomach? That is a more adult question, a more complete question, a heart protective question. Now, number 3, oral decongestants. This is where people get into trouble because the medication feels temporary. It is just a cold, just a few bad days, just a blocked nose, just one stop at the pharmacy. What harm could that do? Plenty if the medication contains pseudoephedrine or phenylephrine, and the person taking it is older or has cardiovascular risk. These drugs work by constricting blood vessels. That is how they clear the nose. Less swelling, more airflow, you breathe easier. That part is real. The problem is that your body does not know you only wanted the vessels in your nose squeezed. The drug circulates through your whole system. Blood vessels throughout the body respond. And now the same medicine you took to breathe can turn into a cardiovascular stress test. Because once vessels constrict throughout the body, blood pressure can rise sharply. The heart must pump against tighter resistance. And many of these medications also stimulate the system enough to raise heart rate or provoke palpitations. That means higher pressure and more cardiac workload at the same time. Picture a 75-year-old woman. Let's call her Margaret. She gets a bad cold. Her nose is completely blocked. She goes to the pharmacy and buys a familiar cold medicine because she just wants to sleep and breathe again. By the next day, her heart is pounding. Then comes dizziness, then a headache, then a blood pressure reading that looks frightening. What she thought was a cold remedy has become a cardiovascular event. And the cruel part is that most people would never have guessed, because they do not think of cold medicine as a heart risk. They think of it as convenience, comfort, something simple. That is why it keeps hurting people. This becomes especially dangerous in older adults with hypertension, atrial fibrillation, coronary disease, heart failure, vascular disease, or a history of stroke. But even people who think their hearts are mostly fine can be pushed into dangerous territory if the spike is large enough or the rhythm gets unstable enough. This is why I tell older adults very directly, if you are over 60 and you have any heart or blood pressure history at all, do not casually take oral decongestants without asking first whether they are safe for you. There are safer ways to manage congestion: saline sprays, nasal rinses, humidifiers, local therapies. Because relief for your nose should never become a crisis for your heart. Now let's move to number 2. Older tricyclic antidepressants. Drugs like amitriptyline and imipramine. This is where the conversation becomes delicate, because mood matters. Pain matters. Sleep matters. Nobody should hear a message like this and assume they are supposed to suffer through depression, insomnia, or neuropathic pain in silence. That is not the point. The point is that older tricyclics can place real stress on the cardiovascular system in older adults, and that risk is discussed far too little. Why are they still used? Sometimes for depression, sometimes for nerve pain, sometimes for chronic headaches, sometimes for sleep. And because they can help more than one problem at once, they remain tempting. But in older adults, they can cause orthostatic hypotension, sudden drops in blood pressure when standing. That means dizziness, instability, falls, fainting. They can also increase heart rate. They can affect electrical conduction in the heart. They can create the conditions for dangerous arrhythmias in vulnerable people. Picture a man in his late 70s. Let's call him Frank. He has diabetic nerve pain in his feet. It is miserable. He is not sleeping well. He is prescribed amitriptyline. At first it helps, then something else starts happening. Every time he stands up, he feels lightheaded. Once, he grabs the wall. Then one day he does not grab it fast enough. He falls. The injury changes everything. And what caused it? Not just age, not random bad luck. A medication that helped his pain while quietly destabilizing his cardiovascular system. That is the pattern I want people to understand. A drug can help one part of life while making another part more dangerous. And if no one is actively monitoring that trade-off, the patient pays the price. This is why these medications are no longer easy, automatic first choices in many older adults. Newer alternatives often exist. Lower doses sometimes exist. Different strategies exist. But none of those better decisions can happen if the original drug is treated as routine and left unexamined for years. That is why older adults and families need to ask, if I am taking this for sleep, mood, or pain, what is it doing to my blood pressure, my rhythm, and my fall risk? That is not alarmist. That is intelligent medicine. And now we come to number 1, the one that surprises people most. Calcium supplements. Yes. The pill millions of people take to protect their bones. The supplement many older adults started on their own because it felt obviously helpful. Stronger bones, less osteoporosis, more protection. That was the story. And bones do matter. Absolutely. But here is where the story becomes much more complicated. Calcium from food behaves one way. Calcium from concentrated supplements may behave another. When you get calcium from food, your body receives it gradually, in a nutritional context, with a slower absorption pattern. But when you swallow a high-dose supplement, you can create a sharper calcium surge in the bloodstream. And the question that has troubled the cardiovascular world for years is this: where does all that extra calcium go if the bones do not take it up right away? That is where the concern begins. Because some evidence suggests that in certain people, calcium from supplements may contribute to vascular calcification. In simple words, calcium ending up where you do not want it. In artery walls, in plaques, in a process that can make blood vessels stiffer, less flexible, and more dangerous over time. Think about the irony. A person takes calcium to make one structure stronger, and maybe quietly making another structure more brittle. That is the kind of trade-off older adults deserve to hear about honestly. Now again, I need to be careful and fair. This area has been debated. Not every study agrees. Not every patient faces the same risk. There are people with real bone disease where supplementation still has an important role. This is not a blanket condemnation, but it is a strong warning against casual self-prescribing and against the assumption that more calcium automatically means more safety. Picture a 70-year-old woman. Let's call her Linda. She worries about osteoporosis. She wants to stay independent. She wants to avoid fractures. So she starts taking a high-dose calcium supplement every day. It feels smart, responsible, preventive. Years later, she has a cardiac event nobody expected because she did not have the classic dramatic risk profile. And now the question becomes one that should have been asked from the start. Was the bone strategy right for her heart? That is why this matters. Because the right calcium decision is not made in isolation. It is made in the context of the whole person. Their diet, their bone density, their cardiovascular risk, their kidney function, their vascular history, their actual need. The heart belongs in that conversation, always. So what should you do with all this? First, do not panic. Second, do not stop medications blindly. Third, make a full list. Every prescription, every over-the-counter medication, every cold medicine, every pain reliever, every supplement, every vitamin, every stomach pill, everything. Then sit down with your doctor or pharmacist and go through it one by one. Ask the harder questions. What is this doing to my blood pressure? What is it doing to my kidneys? What is it doing to my rhythm? What is it doing to my fluid balance? What is it doing to my arteries? What safer options exist for someone my age and my history? Because that is the real message here. Not that medications are evil. The message is this: after 60, common medications can become uncommon dangers.